Good evening. Welcome to one more Y Conundrum. Today we'll be discussing with a famous question, a million-dollar question. And that question goes, why statins causes rhabdomyolysis? First of all, we have to know what exactly is a statin. Yeah, this is a famous question again. So what is a statin? A statin is a molecule which is used for dyslipidemia. Statin is a molecule which is used for dyslipidemia. Now, currently, this is the first-line therapy of choice for treatment of any kind of dyslipidemia, especially when a patient is suffering from increased LDL. We know lots of drugs which is coming under this classification named as atorvastatin. We have pravastatin, rosuvastatin, pitavastatin, simvastatin. Lots of drugs are there, even apart from this list which we have written. But a famous adverse effect. See, usually what we do is a very much commonly used drug in practice. When a patient is suffering from dyslipidemia, we'll start the patient on atorvastatin or rosuvastatin. Very much commonly used drug in clinical practice. We use it around for 10 mg. We used to start with daily night because statins, the mechanism of action is this will inhibit an enzyme named as HMG-CoA reductase enzyme. HMG-CoA reductase enzyme, and this HMG-CoA reductase enzyme is getting inhibited by your statin drugs. Okay, that is the question over here. But usually we administer it at night, like just before bed. We used to ask the patient to take this tablet. But the major adverse effect is we have to give the warning to the patient that if the patient is landing up in severe muscle pain, or if a patient is landing up in like chocolate colored or dark brown colored urinary output, which stands for myoglobinuria, we have to immediately stop administering statins. What exactly is the reason behind? Hi, Dr. Tinu. Hi, good evening. Okay, so we'll be starting with the discussion, buddy. See, statins, whenever it is administered, as I've told, this is going to be inhibiting HMG-CoA reductase enzyme. This enzyme is situated inside the hepatocytes. Inside the hepatocytes, we have HMG-CoA reductase enzyme. Okay. For this, the statin should cross this particular area. The statin should cross this membrane, gain entry into the hepatocytes and bind with HMG-CoA reductase and tend to inhibit it. But statins has to gain entry into the hepatocytes. But how this entry is going to be happening? This entry will happen with the help of a specific transporter. This transporter is named as OATP1B1, organic anion or organic acid transporter P1B1. That is the transporter there. So this organic anion transporter which is present is responsible for making sure that the statins which are synthesized, statins which are administered, is gaining entry into the hepatocytes. Hi Teju, good evening. Hello. Okay. So this statins will be gaining entry into the hepatocytes through this OATP1B1 transporter. But we have some patients where this OATP1B1 gene is going to be underexpressed. This OATP1B1 transporter will be underexpressed, which means lesser transporter will be situated in some patients. They are genetically preponderant. They are genetically predisposed to have lesser number of OATP1B1 transporter. So guess, for example, we have administered 10 molecules of statins for the patient, and we have a 10 OATP1B1 transporter situated on the surface of the hepatocytes, which means all the 10 molecules will gain entry into the hepatocytes. No statins will be remaining up inside the blood vessels. But on the other hand, what if a patient is suffering from a genetic preponderance or genetic predisposition to develop under expression of OATP1B1? Instead of 10, he has only 5 transporters. So what happens? 5 molecules of statins will gain entry. The remaining 5 molecules which are there will be accumulated inside the blood. Now comes the major issue. Statins, whichever is getting accumulated in the blood, is going to be getting redistributed. It is going to be gaining entry into certain other areas in the body, which is a muscle cell. Okay, it gains entry into the muscles. Now, because of this patient is more prone to land up in a famous adverse effect, and that is rhabdomyolysis. So this drug, if it is inhibiting that inside those cells, inside those muscle cells, patients might land up in rhabdomyolysis. Okay, rhabdomyolysis. Okay, rhabdomyolysis. Is that clear, buddy? So now a famous question, what is the $1,000,000 question? Which patients are more prone to land up in statin-induced rhabdomyolysis? Which patients are more prone? These patients who are having under-expression of OATP1B1 gene, these patients are more prone to land up in statin-induced rhabdomyolysis. Okay. Now, how do we identify? Currently, we have this OATP1B1 transporter levels can be calculated with the help of just a basic investigation. But the cost of the investigation is very much high. So, if a patient is developing an adverse effect because of statins, a muscle pain, we can immediately guess that the patient might be having an underexpression. Thereby, we can change the dose or we can change the patient to some other therapies. Hi, Dr. Venkat Shiva. Hi, good evening. Okay. Now comes the next question, guys. Which drug, what if a patient is developing this rhabdomyolysis, which other drug can be given in those cases? This drug which can be given here is bempedoic acid. This is one of the famous drug which is commonly used in clinical practice given in combination with ezetimibe. This bempedoic acid, this will gain entry into the muscles. It will also gain entry into the muscles, but unfortunately, bempedoic acid is a prodrug. This will be converted to the active form with the help of ATP, with the help of an enzyme. We'll discuss about it. With the help of an enzyme. This enzyme which is present here will be less seen, will not be seen, or it will be less accumulated in the muscles. Okay, and that enzyme is, I hope, why am I waiting for it is because it's a famous question used in biochemistry itself, which is acyl-CoA enzyme. This acyl-CoA, especially long-chain acyl-CoA enzyme, is responsible for the conversion or activation of bempedoic acid to the active form. Only if it is getting converted to the active form, we can start seeing the responses of bempedoic acid. But because it is not getting converted to the active form in the muscles, there is less chances of rhabdomyolysis. Well, that's why bempedoic acid is a safer drug to be given, which will not produce rhabdomyolysis. On the other hand, statins might be producing rhabdomyolysis if a patient is more prone, or if a patient is having a genetic predisposition to have underexpression of OATP1B1 transport. Okay, buddy. Well, this is the answer for this Y conundrum for today. We'll meet up in one more session as early as possible. Good night and bye-bye.